I guess it would be Mr. Passerell's turn to inquire on our list here. If you'd like, Bill, would you like to?
Thank you, Mr. Chairman. Thank you to the panel. Did an exquisite job this morning. I have some questions. Just very briefly, Dr. Davis, where does chronic illness, be it asthma, be it diabetes, there's 133 million Americans have at least one chronic disease. Where does it fit into your plan of trying to find meaningful health reform? Very briefly do this because there's only a certain amount of time we have.
I think chronic care and improving chronic care is really at the heart of health reform. I think it's the real potential for savings and the real potential for better care. Only 40% of people with hypertension have their hypertension detected and controlled. What we would build into the payment reform is accountability for working with patients on those conditions. They would get a medical home fee. They would get bonuses if they have a high proportion of their patients with those chronic conditions controlled.
So chronic disease is at the very heart. If we don't address that, we're not really going to get to meaningful health reform.
Absolutely.
I'd like to, we could spend the whole many hours on that subject alone. Let me move on to my second subject here. My questions. I want to ask this question of Mr. Pickering. Some of the members have referred to the area already. I want to bring the example of Medicare Part D into this. I find it a fascinating subject. It's providing a vital benefit to our nation's seniors, but I still believe it has some serious flaws. So choice is a good thing, but we may have too much of it in Part D. Each region has at least 45 plans to choose from, and as many, there's a couple of regions, one of the regions goes up to 57 plans. So an issue brief created by the Commonwealth Fund last year found that the complexity and variation in Medicare Part D may prevent people from finding the plan that best fits their needs. Please follow me. I firmly believe that we must have a minimum set of benefits to make our promise to cover even the sickest individuals. But the term actual equivalence leaves a bad taste in my mouth. I can only speak for myself. So it leaves the door open for insurance plans to tweak their benefit structures, to attract healthier mix of people and leave behind the sick ones. So here's my question. In providing individuals with a choice of private insurance plans, we want to avoid some of the design flaws of Medicare Part D, the prescription drug plan. How can we make a large number of plan choices transparent and easy to understand? And are there any mechanisms we can use to remove the incentives for insurance companies to cherry pick the system? I want to ask you that question.
Okay. Yeah, let me first address Part D. I do a lot of work on Medicare Advantage bids, and the actuarial equivalent is a very real standard. It's very confusing, but it's real. Let me go to the meat of your question. How do we have a large range of plans and avoid cherry picking? I think we need sound insurance principles. We need to avoid adverse selection.
We need to avoid what?
Adverse selection. So, for example, now in the individual market, if we don't have an individual mandate and sick people can sign up for coverage, they'll tend to sign up, healthy people will tend to not sign up, and then you spiral the premium. So, we just need to make sure that we get our insurance principles accurate. And in terms of interpreting the benefit, I think that's something that plans should always strive to offer. The Medicare Part D certainly can be difficult. I know I've helped my parents get through it, and it hasn't been the easiest thing in the world. But
It hasn't been the easiest thing in the world, but I want to avoid those flaws. How would you answer that question, Dr. Davis?
First of all, I think a public health insurance plan should have a defined benefit, as I suggested, modeled on. And it doesn't change, well, it's clear. So in every place, people know what it is and knows what it covers. So having a comprehensive benefit package that's guaranteed. The second would be information that lets people compare plans. We found in the Medicare Part C that some of the plans were charging $40 a day for radiation treatment. Well, you didn't know you were going to get
If she's ready, I'll
cancer.
call her.
And you didn't know that that provision was in there and that you could pay more in a Medicare Advantage plan than you were paying in Medicare itself. So I think some standardization is going to be required on the benefits and clear information so that people can compare.
And finally, do you agree that the major core of debate around reform of the health system is going to center around the question of defined benefit?
I think there are many issues, but I do think having a standard benefit that applies everywhere as a minimum is important. We've suggested the standard option Blue Cross Blue Shield benefit package in the Federal Employees Plan.
Thank you, Mr. Chairman.
Thank you. Ms. Brown-Waite, would you like to inquire?
Thank you very much, Mr. Chairman. I'd like to hear from all three of you on this issue. I have the highest number of people on Medicare, not just in Florida, but of any member of Congress. So many of my constituents are very happy with Medicare Advantage, and they tend to very often be the poorer seniors, the disabled. And the reason why they are happy is either it pays Part B for them, which is over $80 a month savings, and or offer gym plans, silver sneakers, you name it, and they have all sorts of benefits for the seniors. Certainly part of any WellCare plan of preventative illness that we would want to have. What do you say to those currently on Medicare Advantage, and well over, approaching 30% of my seniors are on Medicare Advantage? What do you say to them when those benefits of being on Medicare Advantage may not be there through a government plan? Because they're saving upward almost $90 a month right now. So how do you break the news to people who, how times have changed, people really are very happy in the Medicare Advantage plans? So if we can start, anybody want to jump in here?
Well, certainly I think we need to address the fact that Medicare benefits really aren't adequate for all Medicare beneficiaries. So what the PATH framework does is improve Medicare benefits for all Medicare beneficiaries, again, up to this standard Blue Cross Blue Shield option in the Federal Employees Plan. So the fact that now we have a very high deductible in Medicare for hospital services, that would be eliminated. You get a single consolidated deductible that was more affordable. So improving benefits for all Medicare beneficiaries is the first step. The second is...
But ma'am, first of all, I don't have the federal plan. Second of all, it doesn't offer to have any kind of reimbursement for Part B. And in addition, you know, the wellness plan of, for example, being able to go to the Y for a senior YMCA, use their pool, all their exercise equipment, et cetera, and or saving $80 a month on Part B, that means a lot. So those benefits aren't available in the traditional Blue Cross Blue Shield plan.
Right. No, we need better premium protection, so that Part B would be $100 a month. In addition, for those who buy Medigap, might be paying over $2,000 a year for that supplemental coverage. What this does is to say for any low-income senior, they wouldn't pay more than 5% of their income for their premium. For a middle-income senior, no more than 10% of their income for the premium. Certainly, if a plan wants to go beyond the standard benefits to include fitness incentives, and they do that on a level playing field because they're more efficient or they've got a more innovative way of controlling a chronic condition, then they could use those efficiencies to improve benefits.
Could I hear from the other members?
Yeah, I think you've seen seniors vote with their feet. Medicare Advantage plan has had tremendous membership growth. I think plans have done a nice job of recognizing benefits that seniors want and delivering them in an efficient manner. One element of the program that enables them to do so are the risk-adjusted payments, such that the sicker people have a risk score and the plan is paid based on the risk score, so you're based on a true expected value of that person's cost. That also affects a lot of dual eligible beneficiaries, people that are eligible for both Medicaid and Medicare. Now you ask, what happens if we take those benefits away? One way the plans have been delivering those additional benefits, which are great for the seniors, is that the payment rates to the plans have been higher than fee-for-service payment rates based on MedPAC. So it's, I think it's a fair policy question. Do we want to pay that extra amount over the fee-for-service benchmarks, or do we not?
Well, would the question also be fair to ask, do we want to have healthy seniors and seniors who are able to, and people on Medicare, not just seniors, but everyone on Medicare, able to save the Part B premium cost? That's an offset that I think that we need to address. And I can just tell you that there are a lot of members of Congress who have a high number of people on Medicare Advantage. It's going to be very, very difficult sell to say, oh, by the way, we're no longer going to be having the plans be able to pay Part B for you, and or an exercise plan which is going to keep you healthy and perhaps out of the hospital, and your diabetes under control, and your weight, etc. So that's not going to be a real easy sell.
Thank you. Mr. Kind, would you like to?
Thank you, Mr. Chairman, and welcome back.
Thank
Glad
you.
to have you back in the seat again. I want to thank the witnesses for your testimony today. And Dr. Davis, let me start with you. And first of all, I want to thank you for the work that the Commonwealth Fund to lay out a kind of a roadmap on what healthcare reform should look like. And I enjoyed the conversation we shared at the White House during the Fiscal Responsibility Summit that we both went to just a couple of weeks ago. But let me just get back to an issue that Mr. Pomeroy raised a little bit earlier with you all. And here's my concern. When we discuss healthcare reform, different people, different groups hear different things. For some, it means getting to universal coverage. For others, it means cost containment. Here's my concern. I don't think we can do coverage without also doing cost at the same time, or it will become unaffordable very, very quickly. And I think for too long, and Mr. Pickering, I want you to address this issue as well, but for too long, we've had a healthcare incentive-based system, a reimbursement system that's been focused on quantity instead of quality. And I think that's the real dynamic that we have to change. And the golden grail of any healthcare reform is, yes, coverage, making sure everyone has access to affordable plans, but it's also improving quality and saving costs at the same time. And if we can't do that working together and moving forward, it's going to be very tough to pull this off at the end of the day. And that gets me back to the geographic variation issue, where I come to from an area where we've had high quality of care based on any standard of measurement throughout the country, yet it's one of the most lowest reimbursed areas in the entire nation too. And I hear some of the same concerns with private payers and private plans about the cost shifting that's going on. But Mr. Pickering, isn't it, your theory is that because Medicare under reimburses, that cost gets shifted onto the private plans, and that's why having some type of public health plan option out there is very dangerous, because with the current payment rates, that cost is just going to continue to be shifted to private plans. But the very premise of that is assuming that at the end of the day, we're going to have the same payment rates, we're going to have the same type of reimbursement incentives that exist today. And I refuse to accept that premise as we move forward with health care reform. So would you then agree that if we can change the incentive, move to an outcome or performance-based, quality-based system, as opposed to one that's based on utilization and consumption, as it is today, that that would change the dynamic then when it comes to private health plans as well?
I think we definitely need to change the payment methodology. I think you'd still have a problem of, let's say we move away from fee-for-service, we move to bundled payments. Well, when we do that, quite often when we make a transition like that, we'll do revenue neutral, right? So in the first year, it's the same amount of money to the providers. In that scenario then, if we had a commercial plan that was paying providers 150% of Medicare to start with, they're still going to be paying Medicare, 150% of Medicare in the new system. So somehow we need to figure out, if we put a public plan up against a private plan, how to level that playing field.
Right. Well, I would agree with that. And when I'm talking about the reimbursement, I'm just talking about Medicare or Medicaid reimbursement, but private reimbursement as well. If we're going to do this, we're all going to have to do this together. You can't have one system of reimbursement in the public sphere and then an entirely separate one in the private sphere. And Dr. Davis, you're shaking your head.
Absolutely. I think it's imperative that we address coverage, quality, and cost simultaneously and not just do one. And we need to move away from fee-for-service volume payment to value for what we're paying. And there's nothing to trigger that in the private insurance market unless there's this alternative of the public health insurance plan. I mean, private insurers have had the option all along to move to these methods. So I think Medicare needs to lead. But the main point that I want to just stress is that provider payment goes up. It goes up 73% over this period from 2010 to 2020. It goes up 5.5% every year. Granted, that's lower than the 6.7%.
But the rate of growth would be different.
But we eliminate uncompensated care. We eliminate underpayment by Medicaid. That's a tremendous boost to providers. And
Here's
it
the
gives
rub,
them
and
time
here's
to
my additional
restructure.
concern. You know, in order to get to a quality-based incentive system as opposed to quantity right now, you got to get the HIT built out. It's got to be interoperable. You got to do the comparative effectiveness studies. That's going to take time. So are we going to be getting too far out ahead with reform, dealing with coverage before the rest has a chance to catch up?
Well, we do have a gradual phased-in schedule for the Congress to consider. First of all, it's opened up initially the exchange and the public health insurance plan to just small firms with 100 or fewer employees. In the third year, 500 employees. That really gives providers a time when they're getting extra revenue from coverage of the uninsured, Medicaid reforms, to really position themselves. On the payment reforms, the bundle payment for hospital is also phased in gradually. It starts with just the hospital piece, then adds post-acute care, and then eventually in 2016 adds the physician's inpatient services. So yes, we need time, but we need to get started, and we need to start now.
Great. Thank you all. Thank you, Mr. Chairman.
Ms. Berkeley, would you like to inquire?
Would, Mr. Chairman.
Okay.
Thank you very much for staying, and I'm not addressing, I have some random musings, and then I have a couple of questions, and whoever would like to answer them is very welcome. I think we have a wonderful opportunity to expand coverage, slow the growth of health expenditures, and improve quality. We have a system now that the hospitals hate, the doctors hate, and the patients hate. And in addition to all of that hate, it's unsustainable. We spend a fortune in health care, and we don't get the best bang for the buck, certainly in the industrialized world. In the state of Nevada, I represent Las Vegas, where 70% of the state population is. We have one of the highest uninsured rates in the country. I think we're ninth highest, and that doesn't give me a great feeling to be in that position. The state budget is in a mess, so Medicaid is kaput. The reimbursement is so low, you know, you can't make it up. You can't see a lot of patients and lose money on each patient and make it up in volume. It just doesn't work that way. So many of my doctors just are no longer accepting Medicaid patients. Before the cut, the physician reimbursement cut that we reversed several months ago, I had people in the medical community calling me and saying, look, if you cut this by 10%, I can't take any more Medicare patients. I'm not going to cut the ones I have or stop seeing them. I just can't take any more. If I've got the highest growing senior population in the United States, short of going to medical school myself, so when I go home on weekends, I could care for my constituents, there's no one that's going to be able to take care of them. Now, in the interest of full disclosure, my husband's a nephrologist. My daughter is a family practitioner. She does not make enough money, and he's not real anxious to give up some of his to supplement hers. And I think that's a problem when you're coming up with how you're going to take care of the family physicians. You can't keep robbing Peter to pay Paul. It doesn't work that way. Having said all that, we need to do something about the SGR. If we don't fix this, we have a 20% cut coming up, and that is impossible to lay on the doctors, and we're going to need to do something about that. The other thing is, and I said this in the library before we got started, the way we do health care in this country, in my opinion, is bass-ackwards. We put a fortune into end-of-life care, keeping people alive with extraordinary means. We should be changing the paradigm and putting our health care resources into early detection and prevention of diseases. We will keep people healthier, they will live longer, and we will save billions of dollars of taxpayers' money if we can change the paradigm. Having said that, it makes no sense to me, and I'm just about to reintroduce legislation let me give you an example. I have osteoporosis. My husband had a machine, a bone density machine, a DEXA machine that I tried, and that's how I discovered that I had the osteoporosis. Now I'm taking Fosamax, I'm taking hormones. I'm never going to have a straight back, but I'm not going to have the broken bones that both my grandmothers suffered because they didn't even know they had osteoporosis. However, the reimbursement cuts to doctors for their bone density tests was cut in half. The result of that is many doctors have taken out their machine. Now, the cost of treating osteoporosis patients that break bones and have other side issues is astronomical, and this is something that we can stop with the proper early detection of the disease. Do you think, one, the two questions, what are we going to do with the SGR, and what are we going to do to ensure that doctors get ample reimbursement so they can continue doing tests like the DEXA test to identify problems before they get out of hand?
Well, those are great questions. Certainly, as I understand it, the President is trying to address the SGR in his budget, realizing that it's really accounting gimmicks and that we might as well be honest that we weren't really going to be able to enforce that provision. I think your point about osteoporosis prevention is very well taken. I just heard yesterday about Kaiser Permanente in Southern California having had an aggressive osteoporosis identification and management program having resulted in reduced broken bones. So they've got studies that now document that effect. So one can do that either by rewarding integrated delivery systems that participate in a national health insurance exchange. One can do it by rewarding a patient-centered medical home for what proportion of their patients do they really screen for, get extra money if they do that. I do think we are probably going to have to pit your daughter against your husband and improve primary care compensation. On average, primary care physicians in this country make about $180,000 a year. Most of the specialists, are averaging around $300,000 to $400,000 a year. That's the differential that exists.
May I add one thing on there? The other thing we can do on the machine, if we put the choice back in the patient's hands as opposed to the plan level. If we let the patient choose what was valuable to them, you want to pay, $20 for a copay to use the osteoporosis machine. It should be available to you. You should be able to vote with your feet that you want that. I think if we put pricing in plans where members have cost sharing that reflects price differences that providers can set, a doctor can choose to be paid more with the member bearing that extra cost. So then if you want to go see that doctor, that's available to you. Right now, the plan pays, Medicare will pay all the doctors the one-step fee schedule, and there's no consumer choice.
Thank you all. And Mr. Davis, Kentucky, would you like to inquire?
Thank you, Mr. Chairman. Two things I might highlight that have not been mentioned in this dialogue at all that kind of underpin where I'm going to go with my question is when we talk about qualities or quality outcomes, I have a lot of professional experience in that arena, not in medicine certainly, but out in industry. But we've get into this idea that somehow compensation is unjust if it's dealing with high-risk specialties. The other area related to this is we haven't addressed liability reform, which is at the core of many of the reactive procedures that are driven by Medicare. I've lived this with my mother for a year and a half of her life at the end and saw the incredible procedures that were unnecessary that were done to her so doctors could get paid and also avoid liability. But here's the problem you run into. If you go into a quality situation, and what we haven't talked about is not unlike what New York happened in the 1990s, where cardiac surgeons, to be top rated, had to turn away high-risk patients. And so what you saw were the people being downrated were those who were actually practicing their Hippocratic oath and trying to treat people. I think some premises I want to get a little explanation on from y'all. I would appreciate that, just being a simple manufacturing guy here. But nobody remotely has mentioned the gross inefficiencies of the CMS, which runs on a 1960 system architecture. And there is no way that they can implement a system for which they are not now equipped. The regional RIOs can do it at a local level, but the state can't. We're dealing with high fixed costs and overhead that are imposed on the delivery system no matter what. Secondly, Mr. McDermott made a statement that I have to disagree with, saying that France has the highest healthcare quality in the world at less than half of the GDP contribution or impact that the United States does. But what France doesn't have is the R&D and exportable job creation capability and technology that we've had, nor the speed of delivery, and they have a ration care system. I think their cancer patients would probably rather be treated in the United States with unlimited potential. And the concern, I think a lot of our members here are disdaining actuarial rules. It's kind of like a pilot who decides not to trust the instruments in a storm. Eventually there's going to be a sensory illusion about the system that you're part of, and you're going to crash, which leads me to one real question here. For the commercial sector to work, they've got to be able to market. To not market is not, it guarantees that eventually they're going to be consumed by the state, which holds this, because those 61% of people who have private pay insurance also happen to make up more than the number of people who actually pay taxes in this country, the overwhelming majority of whom pay for their coverage. They also underpin and subsidize the public sector health care delivery. That can't be denied. To say it's the inverse, as one of my colleagues suggested, it doesn't fly with just simple math. And I guess this is the question that I come down to. If any of the premises that I have shared are correct in this, and virtually everything's coming just from historical fact here, how do you justify these conclusions that going to this public system will in fact reduce cost? I don't see that, because what we're actually doing is heaping a burden on, at the same time saying we're going to compensate the providers for a quality outcome that in many treatment modalities is guaranteed not to happen by dealing with this high-risk aspect. I want to see how the government can do a more efficient job at the provision of health care than the private sector can once you remove the economic incentives for individuals.
The two strong advantages of the public health insurance plan are lower administrative costs. So
Okay,
they don't
reclaiming my time, as somebody who's dealt with the computer systems on healthcare in the large corporate world, how do you reduce that cost without changing the CMS system itself, which is flawed?
Medicare doesn't advertise, it doesn't pay commissions, it doesn't pay, I grant, a profit to shareholders.
Okay, reclaiming my time again, you're right. They don't pay commissions, they don't pay, they don't advertise, but the one thing they do is impose a percentage cost on the cost of operations of a medical office. Each medical practitioner that I know of that ran an independent practice had to hire one more staff member to do HIPAA compliance when that was put into force by the CMS in April of 2003. So no, they don't advertise, but they've imposed increased cost on the medical practices and an exponential order of magnitude on the hospitals. Now tell me how that reduces costs for compliance.
I think we do have to worry about administrative cost on physicians. We funded a study, and the biggest single cost on physicians are all the different formularies they have to deal with in private plans. They have pharmacists calling them up saying, your patient isn't covered for this drug, can you prescribe a different drug? So there are high administrative costs, but a lot of that comes because we're not willing to standardize. If we can standardize, we can strip out a lot of that administrative cost.
Based on that, would you say that, that two things have to happen? Would you agree that the CMS needs to be dramatically reformed in its process, and we need to impose realistic liability protections for our providers?
I'm very supportive of both. I think we need enterprise liability for providers that's recommended in our plan, and I think we need to give CMS the resources it needs to do the job.
Would you agree CMS could be better performed if it were downsized?
I think, in fact, they're understaffed, and to take on the responsibilities that we need them to take on. They need to be modernized with their information systems. They need to recruit top talent, but I wouldn't do that by downsizing them.
Yeah, just as closing statement, you don't need to reply to this, but I would suggest that the use of modern technologies would in fact not require a lot of the redundant non-value-adding procedures that our providers are forced to go through to comply with that are generated from this end. And I think every sector of private industry has demonstrated that you can actually redirect those personnel to actual value-adding services instead of non-value-adding compliance. Thank you. I yield back.
Thank the gentleman. And Ms. Schwartz, would you like to inquire?
Thank you, Mr. Chairman, and I appreciate this first hearing, and we're going to hopefully be engaged in serious dialogue about how we're going to accomplish what are been talked about, our dual goals here, which is to contain costs for everyone. And we've heard the President say, and we have said that costs to the federal government, to families, and to businesses, both by financial and, as the physician pointed out, personal ones, are serious and they're unsustainable. And we could do better. We know we can. And I would say that we have actually made some really good progress in just the last few weeks. In the last 6 weeks, we've done more on healthcare than the last 8 years, and we should be extremely proud of that. But what we do know is that we, and I'll mention the expansion of CHIP to 4 million more children in this country. So what you talked about in terms of getting children health coverage is extremely important. Health IT, enormously important to getting the efficiencies and duplications out of the system and being able to make sure we're more efficient and better quality care is extremely important, and deal with what I think you mentioned, Dr. Davis, certainly the very fragmented health system that many of us live with. I represent a part of Philadelphia and a part of the suburbs of Philadelphia. We're extremely proud of our hospitals and our physicians, and yet I know there are strong, and too many sectors of the city that lack primary care providers, lack OBGYNs, that people are not getting the primary care they need. We are having, and it's pretty inefficient, and we're all paying for that. So the first step that I wanted to ask you about, just two things. If we are going to expand coverage, we have to contain costs, and we have to really change in the incentives in our delivery system. And that's the first thing. We had already talked a bit about health IT, talked about some of the other folks had mentioned about primary care physicians. I would like you to just elaborate a little bit on other efficiencies, how we get more primary care physicians. Its payment is part of it, but incentivizing them, making sure that we more incentivize medical homes, more integrated systems of care. Interoperability of information is extremely important, but so is the way we manage chronic diseases and how physicians relate to patients. You might want to mention patient responsibility in all of this, too, and the ability to do that. And if we have time, and I'm going to just put this out there as a second question, is to put out the fact that our insurance system now has been really quite, well, I hope that Mr. Pingering's wrong and that our commercial insurance providers, in fact, can step up to the plate and make real changes. I think if I was an insurance company, and I'm not, I would be extremely upset and disappointed about your testimony that they are unable to respond to changes in the medical system, the efficiencies, reformulating how they reimburse, really dealing with changes that we would hope they can. I hope you're wrong. I think that we can see a competitive private-public partnership, and I hope that we will. But there are clear problems with coverage, and I don't think this has come up at all in this hearing yet. Waiting periods, pre-existing condition exclusions, lack of portability of coverage. I think it was mentioned just about the 2-year wait to get on a public plan for disability. This really, the increasing number of patients have to pay out of pocket for preventative services, so they delay it, particularly in a downturned economy. They don't have the money to do that, and they wait to be able to provide, to get the kind of care they need. So with that, if you could just specifically, and I guess I'll start with Dr. Davis, and then I'd ask you, Doctor, to talk as well about the need for delivery system reform, about the need for insurance reform, so that we can get the coverage we need when we get insurance. It means something to people, it's useful, and that when we have insurance coverage, there are actually providers there that can help us be able to stay healthy, stay well, and reduce the duplications and expenses that we know exist in the system.
Absolutely. I think we need both insurance reform and delivery system reform, and you've ticked them off. I think the design of insurance so that there's such high deductibles, people can't afford preventive care. We've been going in the wrong direction. As you said, lack of portability. HIPAA provides some protection, but that's certain size firms. We need to make sure that people can keep their coverage when they change
So is
jobs.
that federal conditions? We have to make some federal rules about this so that everyone actually knows that they're going to get what they can expect, certain protections.
Absolutely, and that they will not be discriminated against because of their health problems. On the delivery system reform, I think everything you've said about primary care, physicians need time to do care management, care coordination, work with patients with chronic conditions. We need to reform the payment to reward that.
So in other words, we should actually pay them for that.
And pay them for that, as well as a team approach to care. I don't think doctors can do it alone. They need to be able to hire nurses, pharmacists can play a role. And basically, primary care works best if it's part of a larger system. Some people call it a medical neighborhood, but certainly an integrated delivery system that can provide support to those practices, provide them with IT, provide them with care redesign, make sure that those specialty referrals happen easily and smoothly. That's all part of the broader system reform.
Thank you. Mr. Davis of Illinois.
Thank you
Like
very
to
much,
inquire.
Mr. Chairman. And let me just say that I think, first of all, that the best and most effective way to deal with the issues we've been discussing is to have a national health plan, one that everybody is in, nobody is out. And I think once we do that and make it seamless, we will find that many of the problems we're discussing will actually go away. Let me also say it's my belief that the most effective things that we have seen that have helped provide health care to low-income people in this country has been Medicare and Medicaid. It is also my belief that community health centers are the most effective instruments that we currently have to provide cost-effective, quality health care to large numbers of low-income and poor people. And my question actually is to you, Dr. Davis. Would you see the expansion of this network of clinics throughout the country fitting into a plan that would increase access seriously and thereby reduce the numbers of people who are uninsured in this country?
Absolutely. I think our network of community health centers is a vital care delivery system in many low-income neighborhoods. I think they need the support to upgrade their services to this level that we call a patient-centered medical home. We are funding community health centers to do exactly that, enabling them to take a team approach to care, to have services available. But it's a very important part of this, and we would certainly see in a plan designing payment systems that reward community health centers for taking on that responsibility. You also stress the importance of Medicaid. We've talked a little bit about Medicaid maybe doesn't pay as well as Medicare, but it is the safety net for our nation's most vulnerable, sickest, poorest people, and it's vital that that program be maintained for those who are the poorest of the poor.
Thank you very much. And let me ask you, Mr. Pickering, many people feel that there's a great deal of waste and inefficiency in our current healthcare delivery system. If you had to pinpoint some of the places where some of that waste might be, where would you look?
I think the biggest amount of waste is in overutilization. As actuaries, we create what we call cost models, where we have a very detailed snapshot of delivery of care, breaking out inpatient hospital, outpatient hospital, various physician services. We look at utilization per thousand, average cost per service. It gives us the total cost. What we see when we look at the best managed health plans out there, comparing them to loosely managed health plans, is a dramatic difference in utilization. That's directly a cost savings if you can achieve that lower utilization. And usually, you see quality scores correlated with the lower utilization from those organizations that are able to deliver it. So I think that's the biggest opportunity, is to optimize utilization.
And I hope I get a chance to get back to that in a second. But let me ask you, Dr. Avinan, obviously Massachusetts has the highest number or percentage of its population that has health insurance. Are you aware of any studies that have compared the health status of the population there, or the cost with what's being paid overall for health care in other places?
In our committee's work, we completed our review before some of the newer evidence was available from Massachusetts. What we did find, though, was from a whole series of studies and much stronger studies of what happens, for instance, when Medicaid and CHIP coverage has been expanded for children, that access to care improves, and then some important health outcomes like avoiding hospitalizations for asthma. Those hospitalizations are reduced among kids with asthma who were previously uninsured. So I think there are clear indications that bringing everybody into the insurance system and providing good preventive and primary care can avoid some of these costly complications that are not good for patients and their families, and they're not good for us as a society and as a nation, especially when they're avoidable.
Do you think that might reduce cost? I mean, we talk a great deal about cost, and we talk about cost containment. Do you think that might, in a real sense, we get to the real bottom line, reduce costs?
It's a very important question, and what we strive for in healthcare is cost-effective care. Are we getting good value for the money we're spending? There are occasions where we can prevent complications, and it may actually be cost-saving. Most of the time what we're striving for, though, is to achieve cost-effective care, meaning for the dollars that we're spending, we're getting good value in terms of the health outcomes. And we know from a series of studies that extending insurance coverage and covering effective primary and preventive services gets us that good value. We may have to pay a little bit more, but we get much more in terms of a return in improved health outcomes for children that can be lifelong, and then improved health outcomes for the working age population that can help them to be more productive and have a higher quality of life.
Longer life. Thank you so much. I appreciate your answers, all of you.
Thank you. Mr. Reichert, would you like to inquire?
Yes, sir, Mr. Chairman. Thank you. Well, first of all of us here on this committee come from all different walks of life, so we come at the questions in a little bit different way. My background was in law enforcement for 33 years and saw a lot of things, and certainly agree with the statement that the doctor made in your study. Lacking in health care is hazardous to your health. I've seen it over and over and over again in my past profession. So I have some questions that center around the your IOM report It doesn't make any specific recommendations about the shape health care reform should have, but you recommend to the President and Congress that we need to do something now. It's urgent that we do something now. I really have a concern, and going back to someone's earlier question about waste, fraud, and abuse, and overutilization is one of the things mentioned already. How do you propose, and maybe all three of you could respond to this, to address the issue of overutilization or waste, fraud, and abuse? And in my opinion, if we get the government more involved, wouldn't we have more waste, fraud, and abuse?
From the standpoint of an effective healthcare system, the theme's already been emphasized, but I would just echo it that coordination of care is where we can achieve greater efficiency. So when we have a fragmented healthcare system, when people are moving in and out of insurance or unsure what's covered or needing to stop in the sort of a middle of a treatment process when they reach financial barriers, that's when we have an inefficient and fragmented system. And so in order to achieve the health benefits that our report outlines that can come with expanded coverage, that coverage has to emphasize doing what's effective and doing it in an efficient manner. We do that by having primary care and specialty care working together, by having team-based care using nurse practitioners, nurses, nutritionists, pharmacists. We have a great deal of expertise in our healthcare system. We don't always piece it together
Just to interrupt, so coordinated care, I get that, and all three, I think, would agree, all of us would agree with that. Health IT plays into that, right? So we've got $20 billion that we want to spend in the stimulus package on health IT, but we're going to do that by September and October, and we don't have a plan. We don't even know if it's going to be interoperable, but we're going to spend $20 billion. Can anyone address that issue?
Well, I think it's very important that Congress has designated those funds in the America Recovery and Reinvestment Act.
Do you think October is too early, though, to allocate those funds, those $20 billion? Are we ready for that much money out there?
I think it is going to take that kind of investment to get where
I do
we need
too,
to go.
but the timing
You're
of
right. You're right about the
Yes,
strings.
ma'am. Thank you.
It's got to have decision support.
Yes.
So that physicians know what the latest evidence is as they're prescribing a treatment. And it has to have a health information exchange network that pulls data from all the different sites.
How long do you
of
think
care.
that might take? Could we do that in the next 10 months, 8 months?
I think we can set out the standards for what we want in the
Could
next.
we have a national standard?
In terms of the characteristics of the systems, I think what you've charged the Office of the National Coordinator for Information Technology to have those standards by 2010 is a realistic goal. I've certainly seen these systems in countries as small as Denmark, where they have 98% of their physicians on these systems, all of a patient's tests, hospital records, specialist consults are all right there. They're able to do disease registries. They know their diabetic patients who are out of control can bring them in. So there are models out there that we can learn from. So I think it's very definitely a step in the right direction.
I know a lot about interoperability coming from the law enforcement world, and I know we weren't ready for some of the money that came out. I saw cities, police departments purchase systems for $1 million and a year later not work. And that's what I'm concerned about. I agree with you that we need health IT and it needs to be interoperable. We need to be talking to each other. And I also agree that would help coordinate care, would help eliminate some of the waste, fraud, and abuse. But I feel very strongly that we don't have a system in place yet to spend that $20 billion. I'm very concerned about that. I also want to touch on, Dr. Davis, your proposal would require every American to purchase a health insurance plan. There is, for all intents and purposes, a mandate to carry car insurance in this country, but yet 16% of Americans don't carry car insurance. Now, when I was a cop, you know what I would do is when a person got into an accident, I'd write them a ticket for not having car insurance, or, you know, in the event of another stop, I might be able to get that information and write a citation. How do you enforce that, that mandate, that every person have health insurance?
Some countries, again, we can learn from. Netherlands and Switzerland have a mandate. They get all but 1% enrolled, so they do have problems with not everyone. We can use this tax system so people verify their insurance coverage every year when they file their personal income taxes. It may still not catch some non-tax filers. Certainly in Massachusetts, where they've had the individual responsibility, they've gotten the rates up to 97, 98% insured. So I don't think we're actually going to get to 100, but I think we can get to 99% by building on some administrative structure.
Thank you for your answer. Thank you, Mr. Chairman.
Thank you, Mr. Reichert. Mr. Davis of Alabama, would
Thank
you like
you.
to inquire?
Thank you, Mr. Chairman. Let me, if I can, Dr. Davis, start with you and maybe ask you to react to a couple of points. I don't by any means want to adopt the ideology or the theology of my friends on the other side of the aisle who I think are skeptical at the notion of a public plan for ideological reasons, but I do want to pick up on some practical concerns they've raised that I think are actually worthy of some examination. Let me lay out one real-world political scenario that I think is likely to happen here. Let's assume that your plan or something like it were to pass the Congress. There would be an intense political debate around it, and as a practical matter, the opposition would beat up this public plan. They would talk about it as something that wasn't providing the highest kind of quality, something that wasn't providing the highest levels of efficiency. That would be the lines of political debate that would go on in the city, and I suspect in advertising around the country. So as you lay out and as we think about the incentive structure for someone to opt into the public plan as opposed to opting into a private plan, I almost think that we have to factor how people are going to think about the public plan after the political debate and after there's been a systematic effort to discredit it. That strikes me as problematic. Would either you or Mr. Pickering like to comment on that very practical political aspect of this?
Well, I think we heard at this hearing that Americans want choices. They would appreciate having the choice of a public health insurance plan. Medicare is very highly rated by its beneficiaries. We've done surveys of older adults. They would like to be given the choice of buying into Medicare early. And I think our whole experience was Medicare, that yes, physicians expressed some concern about were they going to be paid enough, and it turned out they did very well under these plans. So I think that people are satisfied with the quality of coverage, with their access to services through public health insurance. We've got a lot to build on. But I think what we want is the best of both. We want
Let me interrupt you
and
for
public.
1 second, though, and make sure I'm driving this point home. There has not been a public attack on Medicare for 43 years in this country, so that's why Medicare enjoys a certain political sustainability and durability. It's not under public attack. As a practical matter, even if this plan or something like it were to pass, it would be, I suspect, with an enormous amount of political baggage freighted around it that doesn't exist. It's not tied around the ankles of Medicare right now. I do think that we have to think about that because I think everyone on the panel agrees that we have to have an incentive structure for a diverse group of people in terms of their health care going into a public plan so it doesn't simply become a receptacle for people who have chronic diseases or are low income. And I would submit that if we do anything like this, we have to wrestle with what the public plan will look like after it's been represented or misrepresented in the public debate. Will it be less attractive? Will certain kinds of people be less drawn to it? Will the public debate and the advertising around it create perverse incentives for certain healthy, wealthy, affluent people to opt into a private plan? All of those are factors that I think may alter the incentive structure in ways beyond cost. Now, there's one other factor I think we would focus on. It's not just critical and important to have a level playing field in terms of regulations and in terms of cost structure. I think we're also going to have to grapple with the preemption issues. Hypothetically, if there was a federal standard that obviously covered the public plan, and if some of these private plans were more governed by state standards, that seems to be another thing that we'd have to grapple with to make sure that you didn't have an incentive structure for certain kinds of plans, to not participate in this consortium or network you described. Do any of you want to speak to that issue, how we level out the preemption issues and the whole question of federal versus state law?
Well, you raise good points, but what we know isn't working, and that's the system now. So universally, the polls show that people want change. In Massachusetts, which moved to their system in 2006, polls are very high. People are very satisfied with what they've done there. I think it does require an ongoing education campaign so people know what the truth is about the program, but those who now see that they have economic security, they have choices, they have good benefits, you're going to see much higher levels of satisfaction than we find today.
My time is up, Dr. Davis, but I would just summarize with this observation. I'm not quite as sanguine as you are about comparing this to Medicare, because Medicare is an accepted, established, entrenched plan that has not come under attack in the public debate since 1965. As a practical matter, there would be an enormously contentious political debate around this plan. Whatever we passed would already be discredited in the eyes of significant numbers of people in the country. And I think as we think through the whole incentive structure, that's a really, really big problem, how we deal with the potential baggage that would have attached to a public plan, but my time is up.
May I just one thing you mentioned, we don't want the public plan to become a dumping ground for the sick and the private plans to become a place where the healthy go. I definitely agree with that. And I don't know if in the plan we have risk-based funding like we have in Medicare Advantage, where you know, a chronically ill person who is going to use a lot of healthcare resources, their health plan gets more money for them. They don't pay more premium, but their health plan gets more money. I think you would definitely want to consider something like that so that plans could focus on caring for the sickest without being penalized.
Thank you. Mr. Etheridge, would you like to inquire?
Thank you, Mr. Chairman. Let me thank each of you for being here. And you know, we come to this place after the issue's been raised during a presidential campaign to a high level, at a time when the economy was in a different place than it is today. And I say that because even then, the public was engaged in either one of two things. They neither had health care and wanted it, or what they had was so expensive, and the co-pays and deductibles were so high, they felt they still weren't getting the benefit of insurance. Well, today, we find ourselves in a little different place. The economy is in a different situation. For instance, in my home state of North Carolina, they've just released the new unemployment rates today in North Carolina. Our jobless rate has now jumped to 26-year high of 9.7%. In the last month, it became one of the highest, top 6 in the country in terms of unemployment. And in the last 12 months, it is #1 in the nation in terms of the amount of job loss from January of 2008 to January of 2009. I say that in context because I think this is sort of where we are in a lot of other places. And as Mr. Reichert said, coming from sheriff, I come from having been in education as state superintendent. And so many times we talk about children having health care and the need for it, and that is absolutely true. But last time I checked, most children come from homes somewhere. And if the families don't have the health insurance, it's awful hard, even when it's made available through state, local, federal, wherever, for children to be able to engage in it, because if parents don't have it, they may not get the attention they need. So my question is, they get hit twice. They've lost their job, and in a lot of cases now they've lost their health care. We're helped in the recovery package with COBRA, but for some of these families, COBRA is very difficult because they've lost their job, and in some cases they may not have unemployment insurance. So, Dr. Nair, let me ask your question to you this way, because I think the issue currently, and I think we have to deal with where we are so we can get to where we want to get to, wherever that place may be. Can you describe to us some of the issues that individuals face when they're trying to buy a policy today in the marketplace. I think it's helpful for us to sort of be reminded of that one more time.
And certainly our report addressed a number of those issues. For example, we heard the story earlier about a 62-year-old constituent who'd had a heart attack and had lost her insurance and, was essentially counting the days till she could qualify for Medicare at age 65. So people with any sort of acute or chronic condition, if they aren't eligible for employer-sponsored coverage and don't have a low enough income to qualify for a current public program, they're really very much on their own and adrift. And either if they try to buy insurance on their own in the non-group market, it may not be available to them or may not cover the pre-existing conditions for which they most need the insurance. Or if it is available, the premium may be so expensive that they can't afford it, that it just crowds out the rest of their income. So I think those are clear examples where the people who are losing coverage when they lose jobs, unless, for example, low-income children can qualify for the Children's Health Insurance Program, and we know from previous Institute of Medicine work that when parents and children are covered together, I think you were referencing this, that parents use the system more effectively both for themselves and for their children. So there's a positive spillover effect there across the family when the whole family's covered. These are just some of the ways in which a weakening economy is just going to make the health insurance crisis worse for families and people losing their jobs.
Dr. Davis, I represent an area that's probably representative of America, and we have urban and rural, and one of the real problems we face is that as we try to address, we have in the past, I think, with Medicare Plus Choice, it became Medicare Advantage, et cetera, and insurers sort of rushed into rural areas to sign up beneficiaries and then sort of backed out of that market when the margins really weren't high enough to be where they wanted to be. And some regions of the country only have one option in a plan, which creates some problems. My question to you is, how would the Commonwealth plan serve rural communities and ensure access? Because access is critical as well as containing that cost. If you don't have access, you don't have to worry about the costs.
Absolutely. You couldn't be more right. And one of the advantages of having the public health insurance plan is that you've got a guaranteed, secure, stable option that's available everywhere. As you say, private insurers will move in and out of markets depending upon whether they calculate they can make the kind of return for their shareholders they want to make. So it's very important to have a public health insurance choice that's available, particularly in the kind of rural area that you've mentioned.
Thank you.
Thank you, Mr. Chairman. I yield back.
Mr. Boosty, would you like to inquire, sir?
Thank you, Mr. Chairman. You know, as a cardiac surgeon with over 20 years' experience in an academic center, public hospitals, and a very successful private practice, I could talk at length about the problems with the healthcare system, both in the private and public sector. My friend earlier from Alabama mentioned that he thought that those of us on our side have an ideological skepticism. I would submit that I have a very deep skepticism of having a government plan competing with private plans for the simple reason, and that is, what's in the interest of the patient in terms of high-quality medicine. Now, a couple things I want to point out. One, we have a significant, long-standing and extensive liability with Medicare and Medicaid. That has to be addressed, and there are no plans to do that. So, as we look at a plan that will potentially push more people from the private sector into the public sector, and Dr. Davis, the Lewin Group that contributed to your research, has concerns that 120 million Americans would lose their current private coverage under your plan. There's a real problem here, and we need to be careful with this in the interest of real quality patient care. Secondly, access to a doctor-patient relationship is very different than coverage. I know Dr. Ayanian knows that as a practitioner. There's a profound difference. And one of the things that's missing in all of our government plans to a large degree right now, in Medicare, Medicaid, and SCHIP, is that difficulty in developing the doctor-patient relationship. There are access problems to the doctor in the development of that kind of relationship in all three of those programs. It's worse in some than others, but it's there in all of them. One of the things that we know, in addition to this, is we've got a significant shortage of healthcare providers looming and getting worse. Dr. Ianian, if you would speak to Dr. John Meyer at the Brigham Hospital, a cardiac surgeon, he would be the first to tell you that half of the cardiothoracic surgery spots in the country did not fill last year. That's half of 139 training spots. If we don't have cardiac surgeons, cardiology programs go away, pulmonology programs go away, intensive care units tend to disappear. We also, at the base, are losing our primary care and our general surgeons. Rural care is going to suffer. If we don't have the providers, we got a problem. And that's another major issue that relates to reimbursement. And currently, the healthcare system is basically a price-controlled system across the board. Medicare rates are determined very arbitrarily, and in the private sector, they're pegged at some multiple of Medicare. And this is creating a severe distortion throughout the healthcare system that's hurting access to developing a doctor-patient relationship. So I guess my question would be that if we shift patients from the private sector into government-run healthcare, which is going to happen, what are we going to do about the longer waiting lines and the difficulty in gaining access to developing a doctor-patient relationship, which is the essence of quality, where prevention and screening and early detection really take place?
I'll speak to the importance of the healthcare provider community, the physicians, the nurses, the people on the front lines. You and I have experience in practicing ourselves and collaborating with our colleagues. While this debate is sort of, for most of today, has been about insurance
and coverage,
and
yes.
coverage, and that's critically important, I think it's clear that the provider community, the doctors, the hospital leaders, the nursing leaders, need to be brought into this, and we have had some discussion today about not just reforming the insurance system, but reforming the delivery system. And ideally, our healthcare system works best when those two sort of work together as opposed to in opposition to each other. And so it's clear from the work that we've done at the Institute of Medicine that we need both pieces. We need the coverage, because without coverage, it's very, very difficult to even have a chance of getting that effective doctor-patient relationship that you're highlighting.
What I'm pointing out is that as we work on coverage, we have to keep our eye on the ball and make sure that the access to doctor-patient relationship is also given at least equal treatment, if not more, because some of these coverage decisions, I'm fearful, are going to lead to severe access problems, which we're already seeing today in the current healthcare system.
And so I think that just underscores that, we need a very thoughtful approach. It can't just be expanding coverage and then sort of into a delivery system that's malfunctioning.
And that's what I find missing in much of the debate we've had and in the proposal put forth by the Commonwealth Fund. And it's a very deep concern as somebody who's had extensive experience with this at the ground level. The other thing is, there was some mention of alignment of incentives, which is critically important. And there's so many legal impediments to doing this in healthcare today that this is another issue that I think needs to be addressed if we're going to actually get to that point of quality. And I see that my time's expired, so
Thank you, gentlemen. And I'd ask if Mr. Levin wants to inquire. And
thank you very much. Welcome. A long day for you. By the way, I haven't been able to be here the entire hearing, but I did hear some discussion about IT, and I just want to indicate, based on what I've heard from across the board in the health field, as well as my own family's experience, I think there's a thirst for information technology. And I do believe that the money that was appropriate is an absolutely essential breakthrough. And I have confidence it will be administered effectively. So let me just ask, and Dr. Davis, I'll start with you, and others may want to comment. There's been a lot of discussion about a public plan, and I heard it suggested that maybe its nose may be bloodied so much that people won't be attracted to it. I don't think that's true. I remember when I was first here, or a few years after that, there was some discussion about Medicare and some complaint about the new system, and some seniors were not entirely happy with it. But those problems were straightened out, and the DRG turned out to be workable. So I really think one of the basic issues is not whether there'll be public support for a public ingredient, but whether the support might sooner or later be so strong that there wouldn't be private competition, that it would become essentially the only option or the main option that was exercised. And I think we need to get right at that, because I think underlying the arguments against this plan in part is the belief that what we're starting with here is what we would necessarily end up with alone. So Dr. Davis, do you want to start talking about the whole relationship between the public and private sector under this plan?
Well, I think the most important point to stress is that nobody loses coverage. People have choices, and they only change coverage if they feel that what they're changing to is better or more affordable. I think that having a public health insurance plan provides a challenge to change business as usual in the private insurance industry. I met last week with the executives of the Wellmark Blue Cross Blue Shield plan of Iowa and South Dakota. Their board has given them a charge to have their premium trend be equal to the consumer price index. So they are on a journey to get premium increases down to the same as general inflation. I think we're not suggesting something as tight as that or as ambitious as that, but certainly a plan like that would fare very well in a national health insurance exchange where the goal is to slow spending to 5.5% a year, substantially above the consumer price index. Private insurers have strengths. There are ways that they can adapt to this. First of all, they can pay according to these innovative methods, so it can't just be Medicare, Medicaid, and a public health insurance plan. In addition, if something better comes along, they can be very quick to innovate and test that. They can modify benefit designs if there's a change that attracts individuals to their plans. They can have effective utilization management. So some think it means the demise of private coverage and we'll just march toward public coverage. I think we'll have a healthy balance between the two, and they'll both find the kinds of patients, the kinds of enrollees that are attracted to the strengths that they bring to the table. The main thing is to change competition in the insurance market so that everybody's bringing value added. They're bringing what they do best that winds up getting us better value for the dollars we're spending.
Well put. I have less than a minute, Mr. Pickering or Dr. Vanya. Either of you want to quickly comment?
I'll quickly comment. You know, if it happens that the public plan is so good that everyone wants in, well, that's a good problem to have. I guess you lose the value of competition to drive future efficiency, but you've succeeded in creating a good public health plan.
Geez, I hope your message is heard. I think Dr. Davis indicates that the competition is likely to continue and would be healthy for health. Dr. Vanyan, do you want to? I have 15 seconds, less than that left.
Just to echo that the important issue here is to get people covered from the Institute of Medicine's perspective, that the longer we wait to achieve that goal, the more negative health consequences that we're going to experience among Americans and for the country as a whole, and that has a real human cost that we need to keep our eyes on and keep as a motivation going forward.
Thank you for this excellent hearing.
Thank you. Mr. Meek, would you like to inquire?
Thank you so very much, Mr. Chairman, and I want to thank our witnesses for being here. Been monitoring the hearing, and I must say from Florida, as you know, we are almost ground zero as it relates to health care, and I think we'll be a big part of health care reform. I wanted to ask a question about doctors and how you think we'll be able to meet the demanding needs of doctors right now. In Florida, average age of the doctors that are there that are what you may call general docs and that deal with issues, primary doctors that are dealing with a number of individuals in Florida that are getting older and older. We had a physicians in teaching hospitals to allow more of those physicians to be authorized in the future to be able to meet the growing needs of Florida. And I will tell you, in 15 years, many of our docs would have aged out, and a number of them, as it relates to this health care reform, as we look at cost, will they be properly incentivized to be a part of any reform that we're trying to carry out right now, and also be willing to go into the medical profession in Florida or in other parts of the country? So my question is mainly going down the line of how do we address the issue of the failing recruitment, I think, and getting more young doctors involved in the healthcare arena? Any of you can answer that question?
Speaking from my perspective as a physician working in a teaching hospital, and really this is not directly addressed by our Institute of Medicine report, but I think we need to recognize that physicians are attracted to the field for the opportunity to be healers, and most physicians want to focus their energy and attention on taking care of patients. And so to the extent that health reform can reduce the administrative burdens on physicians and free them up to focus more on what the calling of medicine is, there's, I think, an opportunity to make medicine and other health professions even more attractive to young people considering different career options. So I think that's a perspective that I have, that if we come back to, if we can reduce some of the administrative hassles and the fragmentation in the healthcare system, and a sense that everyone's a part of this, that all Americans are part of the system and can gain coverage, that makes the calling of medicine much more attractive.
When we talk about docs in Florida, we talk about, of course, in your report, you talk about the quality of, improving the quality of care. And many of the docs who I've spoken to are saying, Kendrick, I don't know who's going to come behind me to do this job under this environment. And as we look at opening this book of healthcare reform throughout the country, especially as it relates to coverage, as it relates to docs that are practicing outside of, by themselves, will they be able to still be in the profession of providing medical care? And many rural areas, not only in Florida but throughout the country, are finding themselves in a situation where they're traveling for miles and miles and miles because no one wants to come to their community. So that's where I'm trying to go. It was a broad question, but I'm just trying to go there and how we can deal with it as a committee, because sometimes we may lift the hood of a car and may not necessarily twist the spark plug the way it's supposed to be twisted to get the kind of fire you need to start the engine. So that's a concern, and probably will be some dialogue, because when you start talking about first controlling costs and then trying to improve health care, you have to think about those that are in the healthcare profession, if they're going to be able to meet the requirements or the threshold that we call ourselves, reforming on behalf of the many. Insurance is another issue for many doctors, and something that we have been trying to address. So I'm just trying to figure that out, because I feel that we have a lot of folks that are finding areas, and in this report, how we can do it. But those professionals that are there, especially the docs, it's important. And we know nurses, shortages, and all of that, but how do we incentivize them?
Well, and our report speaks directly to this in terms of spillover effects.
Yes.
So communities that have high rates of uninsurance are less able to attract physicians, period, and less able to attract high-quality providers to their communities, or to retain the ones that they already have. And when healthcare systems or hospitals look to make investments, it's less attractive to them to make those investments in communities where there's high rates of charity care and uninsured patients who may just not be able to seek care when they need it and use those services to their benefit. So clearly there are these spillover effects that could be we could use in a positive direction if we raised rates of insurance. Communities that currently have high rates of uninsurance would be better positioned to attract and retain the healthcare professionals and the medical services that they need.
Thank you so very much. Looking forward to working with you. Thank you, Mr. Chairman.
Mr. Roscoe, finally, sir, your patience, and thank you for, Wade, would you like to inquire and
Yes,
see our wrap-up?
Thank you, Mr. Chairman.
Thank you.
And to all the witnesses, thank you very much. It's clear to me that you're thoughtful people that are taking on a very serious, complicated issue, and I for one, and I know I speak, I think, for everyone, really appreciate the depth of thought that you've given to this. You know, I was reflecting, Dr. Davis, in your conversation with the gentleman from Kentucky a couple of minutes ago. You talked about the liability reform side of things, and we had OMB Director Peter Orzog here last week, who shared with us a story of his own personal experience, and it was kind of interesting. It's not often that people come before a House committee and disclose medical information, but he said that he was a runner and had recently had some sort of an episode with his leg or his knee, went to the physician, and the physician said, yeah, there's something going on, and let's do an X-ray. The X-ray came back positive. My memory is that Director Orzog sort of resisted the physician's next line of diagnosis, which was an MRI. And the director said, well, what is that going to show me? And according to him, the physician said, nothing really, but it's kind of what we do. And the director was a little bit proud of himself, I must say, and he said, well, I don't want that test, I'll be okay, and off he goes. I thought about that a little bit, and I thought, you know, that's great, but what if it hadn't worked out well, right? What if the director had actually had some subsequent injury that got worse and worse and worse? And, you know, memory may fade about what that visit was actually like. So I got to thinking, what would it be like if Marcus Welby, MD, was Dr. Orzog's physician? And it didn't work out well, and Dr. Orzog filed a malpractice case against Dr. Welby. And I think this is a couple of lines in a cross-examination that I would do if I was the plaintiff's lawyer against Dr. Welby. And you could just imagine Marcus Welby on the stand, and you'd say, Dr. Welby, Peter Orzog was your patient, isn't that right? Yes. And he came in complaining of problems with his knee, isn't that right? Yes. And they were enough complaints, Dr. Welby, that you thought it was wise to get an X-ray, correct? Yes. And there were positive indications of trauma, isn't that right, Dr. Welby? Yes, there were. And your first instinct was to order him an MRI, isn't that right, doctor? Yes. And the reason it was your first instinct, doctor, is because you've had the training, and it's the standard of care for reasonable and prudent physicians who are in your ordinary area of practice. Isn't that right? Yes. But he talked me out of it. Well, Dr. Welby, Peter Orzog never went to medical school, right? Right. He never had any residency training, correct? He's never seen a patient. He's never read the medical literature. So you let yourself be talked out of a reasonable and prudent, you see where I'm going with this. Okay. So, Dr. Davis, when you said that you were in favor of liability reform, I heartened a little. And I thought, oh, great. You know, that's sort of an unconventional thing coming from a majority witness. And then I read the liability that you're proposing, and it's really not what the normal conversation about medical liability is. In other words, what you're doing is recrafting, in your words, enterprise liability to create an interlocking liability relationship between physicians and other entities, presumably hospitals and so forth. But you're not really, I mean, this plan is silent as to the duplication of testing, the defensive medicine that is sort of inherent in things. And I just think it's important, would you acknowledge that defensive medicine is driving costs up and that is something that has to be dealt with? Or, and just tell me if it's true, is the orthodoxy from your philosophical point of view, is it impossible to contemplate that caps on non-economic damages make sense in a system when we're trying to control costs?
Yeah,
Truthfully, I've never seen a good study on defensive medicine. People toss out numbers, $1 billion, but when you really look into them, the good data aren't there. What I would recommend, and what we're funding to evaluate in the state of Washington, was legislation that gave protection to physicians in liability cases if they had systematically given their patients what is called shared decision-making, which is not just some advice that Dr. Orzach got, but say a video that explains very carefully the risks and benefits of getting surgery, not getting surgery, getting an MRI, not getting an MRI. If the physician has the patient be educated about their treatment options, the risks and benefits, then they are protected in liability situations because they've at least informed the patient. The patient decided they didn't want the surgery, didn't want that test. So we're funding an evaluation of the effect of that on quality, on outcomes, on cost. But I think that's a very intriguing way. I certainly would favor that over something very crude like caps on damages for pain and suffering.
My time has expired, but I'm interested in following up with you, particularly about the definition of, well, the nature of that protection from a liability point of view, because as you know, the devil's in the details on that. But thank you for your testimony today. Thank you, Mr. Chairman.
Thank the gentleman. And I would just point out that in California, where we did cap it, they didn't lower the premiums to the doctors. The insurance companies charged more, but there was no real savings to the docs. So a lot of that is how these caps are carried out in fact. Mr. Camp.
I would just say, first of all, thank you all for being here. And I think one of the concerns that many of us have with a government option competing against private plans is that the private plans would all be required to meet the criteria set forth in the government option, but wouldn't have the subsidy the government option. And therefore, over time, there wouldn't be any competition. I mean, there are no private plans for people over 65 for a reason. They can't do it. Yet, we know Medicare isn't always adequate because 42% of seniors have Medigap insurance. The other concern is, I think, one that the government plan causes private plans to charge more, as more people would be eroding off private insurance and into the government program, because there is cost shifting, and we've all agreed, at least certainly in Medicaid, we can agree there's cost shifting, and there are seniors on Medicaid, and physicians certainly have that issue as well, that then further erodes, again, private insurance. And for us to really continue to have people have the insurance that they not lose what they have, we cannot see the erosion of the private side. Now, I don't really see a way around that, frankly, and maybe it's that, and I guess I'd like to hear you comment on that particular part, and maybe it is that the government sets some basic criteria for plans as opposed to being in the insurance business themselves for those that are not on Medicare or Medicaid. And I guess I'd like to hear any comments that you might have on that. Anybody? I know we're nearing the end of this hearing. Yeah, thank you for all of the time you've spent this afternoon.
It's late in the afternoon for an economic theory on cost shifting. I use as a test is what does a payer pay enough to get the providers to participate? What Medicare pays is enough to get hospitals to participate. It's enough to get nearly all doctors to participate. It's not enough to get them to participate in Medicaid. So that, to me, is a problem. I'm comfortable with that kind of evidence. I personally don't think there is a strong empirical database that says if Medicare pays a lot more, if we pay for the uninsured, if we raise rates for Medicaid, that commercial insurers will cut rates or that providers will be happy taking less money because now they're getting a lot more money from Medicaid patients and from uninsured patients. But if you believe it, then private premiums should come down, not go up, because there's a huge infusion of funds for covering the uninsured $100 billion and a huge infusion of funds for bringing Medicaid up to at least Medicare level.
And we have seen premiums go down in Part D from where they were projected to be.
Yes, so unfortunately in economics, we never know what would have been the case if we hadn't done
Well,
that.
well,
But
we
you're
had
right, the
we had
premiums
a
were-
potential amendment that the premium should be $35, and clearly you can get a Medicare Part D plan for much less than a $35 premium. So that would have been the wrong approach.
My friends who are actuaries are very good at extrapolating trends. They sometimes miss turning points. Prescription drugs peaked at about the time the Medicare prescription drug law came in. So they were projecting Part D plans on the basis of that upward trend. So whether they overestimated what the premium would be and it came in lower, or whether it was the market working, I think we'll never be able to.
Well, and some of that's the more extensive use of generics. I understand that it's not all competition. In a sense, it is, but there are other alternatives that have helped contribute to that. I'll freely admit that.
But I think the basic argument is that private plans should be able to participate with a public health insurance plan that pays fair rates. That they can adopt those rates if they want to in private plans. They can do something better than that if they want to. They can use all the other tools that are available to them that are unlikely to be adopted by a public health insurance plan, like selective networks, like utilization reviews, like benefit design. So certainly, I think the worst case scenario is what you see in this report, that they just keep on charging what they're charging. But even with that, they would still have over 100 million who are privately insured. Plus, they would have the business of paying the claims on all of those people covered through the public health insurance plan, just as they pay the claims under the Medicare program.
If everybody's inquired, I want to, first of all, ask the witnesses to raise their right hand and take a pledge that they won't tell any future witnesses how long you have to sit there on those hard chairs when you're a witness, but to thank all three of you for participating with us today. I think it's been a useful hearing, and I really thank you for your patience, your indulgence. We've enjoyed working with all of you. Hope we can have you back. Thank you very much. And
hold it. Pete had an idea
Mr.
that
Chairman?
I hope might be receptive to you, and that is that if we get close to resolving this issue, whether we could have an informal roundtable without the mics and the testimony, including Republicans, to be able to, not in 5 minutes, but to get normal conversations about problems that all of you know that we're going to have. And you, Karen, you've dedicated your life to this, and so we're going to staple you to the bill and just send it to the floor. But we really want to thank you for sticking with us today. This is the first, and I'm convinced that we're going to work this out. Thank you so much.
Thank you.